Hello, I hope you guys are doing well. Today we are learning about, sorry, I'm trying to make it full screen. Okay, today we're learning about traumatic brain injury, concussion, Parkinson's disease, that's in this lecture, and then the next PowerPoint will have MS, multiple sclerosis, ALS, Guillain Barre Syndrome. So we have quite a few neurological disorders that we're learning about today, starting out with traumatic brain injury. Okay, so traumatic brain injury is a direct injury to the brain. It's caused by traumatic force. There's open injury and closed injury. The open versus closed is talking about the skull itself, not the skin. So if the skin is open but the skull is intact, it would be a closed injury. So the skull has not been penetrated. If the skull is penetrated, it's considered an open injury. Primary injury and secondary injury. So the primary injury is directly caused by impact. This damages the axon, it causes cell necrosis or death, it disrupts the blood-brain barrier, can do any of those things depending on the impact. Coup, countercoup is referring to, coup is the exact point of impact. Countercoup is the force causing the brain actually to hit the skull on the opposite side. So if you were in a car accident and hit your head on the dashboard, the front of the brain would be injured based on the impact. And if you hit it hard enough, the brain would bang into the back of the skull, and that area would also have an injury. So that's a coup, countercoup injury. The secondary injury are in response to the initial injury. It's typically related to inflammation and poor perfusion. So perfusion is the blood being able to deliver its nutrients, including oxygen, to the brain, to the area. And so some of the complications, sorry, I thought I had specific complications I was going to tell you. But anyway, some of the secondary things could be additional edema. It could be additional cell death because of the edema. Could be a bleed in the brain, things like that. Epidural hematoma is between the skull and dura. You don't have to memorize that. I just want you to be familiar with that word. Subdural hematoma, the veins rupture between the dura and arachnoid. So here's kind of a little picture of the different parts of the area surrounding the brain, and different injuries can cause effects on different portions. All right, levels of consciousness. So most of us are familiar with a coma. A coma, you are unconscious and unresponsive to all stimuli. With a stupor, you're generally unresponsive, but with arousal or repeated arousal with repeated stimuli, they may be able to wake just a bit. So that's the type of people, as they're waking from a coma, that they're generally unresponsive, but if you squeeze their hand over and over, they may squeeze back. Or if you tap somewhere over and over, they may lift a finger or move a toe. That's called a stupor. Okay, so with continued levels of consciousness, obtundity, that is basically a sleep state with decreased alertness and delayed response to stimulus. So you have to do a lot to get them to open their eyes, but occasionally they will open their eyes. They may even follow a person that's moving. They may even have the occasional smile or squeezing of the hand to a command, but it takes a lot to increase the level of alertness to get any type of response. With delirium, it's a state of confusion, disorientation. Typically, these patients are agitated and loud. So they're starting to wake up, but they don't really understand what's going on. So they're irritated. They have all these things in their body they're not used to, and it's frustrating, and they are agitated and not alert enough to understand what's really going on. With the clouding of consciousness, it's more of a quiet behavior. There is some confusion. There's poor attention. There's a delayed response, but they're awake more of the time and a little bit more alert to what's going on in their surroundings. With the conscious, they are alert, oriented, aware, and able to remember. So we test people's level of consciousness. And one of the things that we do is test their orientation. So we'll ask them, who are you? Where are you? What date is it? And that's being, if they're able to answer all those questions, then they're alert and oriented to person, place, and time. And that kind of tells you that they are fully conscious and aware of everything that's going on. All right, intracranial pressure. That's pressure on brain tissue. It's exerted by the cranium, the dura mater, the cerebrospinal fluid, and circulating blood volume. Cerebral perfusion is a ratio between your blood pressure and your intracranial pressure. So as blood pressure increases to a certain extent, cranial cerebral perfusion increases. As intracranial pressure, the pressure within your brain increases, perfusion decreases. Also, if blood pressure is too low, your cerebral perfusion decreases. And why it's important is because it determines how much oxygen is actually, and nutrients, being delivered to the brain tissue. So if your cerebral perfusion is high, you're getting a lot of oxygen and nutrients, and your brain is active and able to be used. If your cerebral perfusion is low, then you may pass out, maybe an altered level of consciousness, or if nothing else, experience symptoms of hypoxemia, low oxygen to the brain. Okay, so with increased intracranial pressure, I basically just said some of this. It leads to ischemia, it leads to cell death. So when the pressure is too high in your brain, then the nutrients and the oxygen can't be delivered adequately. And so then ischemia just means low oxygen. When there's low oxygen for a long time, it can cause the cells to die. Some of the signs are headache, confusion, shallow breathing, increased blood pressure, nausea. Could get worse as it progresses, but those are signs of increased intracranial pressure. With decreased intracranial pressure, that typically occurs when the blood pressure is too low, if it suddenly drops, or if there's significant blood loss. There's been trauma, you're bleeding out somewhere, and most of the signs there, most of the time the body will faint, because when you faint, you fall down, the blood is down in more of a gravity-dependent position, and more blood can perfuse to the area. And if it's bad enough, then it will cause death. So too little blood perfusion, cerebral perfusion, will lead to fainting and death. Now, some of the warning signs before they get to the fainting part are dizziness, turning pale, ringing in the ears, blurred vision, feeling faint or lightheaded, suddenly feeling warm and sweaty, nausea. So I'm sure a lot of you have experienced that at some point in your life when you either lock your knees too long, or for me, when I go upside down on a roller coaster and you start to get some of those symptoms and you're like, I need to sit down or I'm going to faint. So ideally, you have them sit or lay down so that they avoid fainting. All right, so some of the techniques we use while someone is in a coma or when they're waking from a coma to assess the patient and to determine their functioning and where they are is the Glasgow Coma Scale, the JFK Coma Recovery Scale, Disability Rating Scale, and Ranchos Los Amigos Level of Cognitive Functioning Scale. It's not something you need to memorize all this, but we will talk in depth about the Ranchos Los Amigos Cognitive Functioning Scale. I will want you to know those. The others, you'll just have to be familiar with what they are and how they're graded if you're working with patients who have, been in a coma or are currently in a different state. Glasgow Coma Scale. Some of the ways that they assess is they look for eye opening, and then a score is given whether it's spontaneous, they're able to open and close their eyes at will, whether it's only to somebody talking or to pain, or if their eyes are not opening at all. Then they look at their verbal response. Are they oriented and able to be appropriate with what they're saying? Are they confused, so they're talking but it doesn't make a lot of sense? Are they using inappropriate words, maybe some just babbling and incomprehensible speech? That's the next level, incomprehensible. So inappropriate would be more like babbling and saying things that don't make sense. Incomprehensible, you can't even understand what they're saying, and not speaking at all would be the lowest level on that. With the best motor response, at best, are they obeying commands? Are they able to show you where they hurt or to at least look at a painful site when you touch it? Are they able to pull back and withdraw from pain? Do they flex reflexively to pain? Do they extend to pain? Those are kind of reflexive responses that tell you where their brain is, or do they have no response to pain at all? And then the total score, 3 would be a deep coma or death. If they're not responding, motor, no verbal response, no eye opening, then they are in a coma still or death. If they are able to do all the top functioning things, then they're fully alert and oriented. And then there's a wide variety of in between. Okay, Ranchos Los Amigos. So cognitive functioning scale. So there's 10 levels, and the patient is given a level based on what their function is, and based on what level they have tells you what you are able or expected to do with, as far as physical therapy and treatment goes. So with level 1, there's no response. The person is in a deep sleep. Level 2, there's a generalized response. The person can inconsistently react, but not directly in response to stimuli. So you're not saying squeeze my hand and they squeeze it. They're not there yet, but occasionally they may open their eyes or move a finger. With level 3, there's a localized response, and they are still inconsistent, but they may respond to direct stimuli, like you squeezing their hand and saying squeeze my hand. They may occasionally squeeze back. So the first 3 are all responses. They're based on their responses, whether it's a no response, generalized response, or a localized response. Once we get to level 4, we call this the feisty 4s, because typically as they start to first wake up, they are confused and agitated. Again, they're in an altered state where they don't understand what's going on, but they feel all these things that are, they might be in pain, and they have all these leads connected to them, and so they are agitated. So we call it the feisty 4. So the first 3 are responses, various responses. Level 4 is the feisty 4s, where they're agitated. And then level 5 and above, let me see, level 5, how do I remember that one? They just become more and more appropriate. Level 5 and above, they become more and more appropriate as far as their reaction to what's going on in their surroundings. So in level 5, they're still confused. They're still inappropriate. And this doesn't mean like making sexual gestures or something like that. That means, you're saying raise your arm, and they just wiggle their toes or something. They're not appropriately responding to the commands. But they're not agitated anymore, more of just confused and not able to follow commands. That's a level 5. With a level 6, the person starts to begin to be appropriate. You say, squeeze my hand or lift your arm, and they're starting to be able to follow those basic commands, but they are still confused about what's going on and what happened to them. Level 7 is called automatic appropriate. So they're able to do automatic responses. For example, putting on a shirt, something they've done their whole life. They may be able, you hand them a shirt, they may be able to put it on. But if you said, what do you need to do? Tell me what you need to do to put on a shirt. They may not be able to verbalize it. Just automatic responses, things they're used to doing. Give them a toothbrush or a hairbrush, and they can, use it appropriately. But it's just automatic responses. If you give them a more difficult task or try to give them instructions on how to go through the task, then it's much more difficult. With a level 8, this is purposeful appropriate. So they have more functioning memory. They're more appropriately responding to the environment. It's common for them to display depression because now they're becoming more and more aware of their condition. And the others, they may not be aware of their deficits, but at this point they're starting to realize, I can't do this anymore, and I'm frustrated, and it's really disappointing how my life has changed. So in this state, they're more aware, and they're able to remember, the therapist came yesterday and I couldn't do it yesterday either, so now I'm more frustrated. A lot of times people will stop at this stage or remain in this stage for a long duration. They may eventually get past it, but many patients, this may be where they kind of plateau in their progression. Now, level 9 and 10, they just become more and more appropriate. So with a level 9, typically they're independent enough that they just need someone by. Let's say they live with a spouse who is cognitively with it. They may be able to care for themselves, but they may need some cues, some reminders, occasionally some assistance from the spouse. Versus a level 10 is modified independent. They're able to live by themselves, to do what they need to do, but maybe using compensatory strategies. They may have to use special devices to help them with certain things, or they may have, awkwardness in their gait or the way that they handle objects, but they're able to do them independently at a different rate. Might be the speed or the accuracy of the movement that's different, but they are able to complete the task. All right, so to simplify it, the first three levels are responses: no response, generalized response, localized response. So it's none at all, it's big, and then it's more localized, getting more specific. 4 is the feisty 4s. That's when they're agitated, starting to wake up and getting agitated. 5 is confused, inappropriate, so they cannot follow commands, cannot do basic tasks. With 6, they're still confused, but they may be able to follow basic commands like lift your arm. 7, automatic appropriate. You give them something to do, put on a slipper, and just hand them the shoe, and they can do it. But if you say, what do you need to do to put on a slipper? Or now lift your arm, move your foot, and give them 3 commands. They aren't able to follow those commands, but if it's something they're used to doing, they can automatically complete that task. With level 8, they become more and more purposeful. Typically, they still will need help with most, if not all, their activities. And at this point, remember, they are getting more aware of their deficits, which is kind of a hard thing for a lot of people. With level 9, they're getting more and more purposeful, more independent, more able to do the things themselves, but requiring someone to be kind of on standby to help if they need it. With level 10, this is our person who's now at a modified independent. Their life is a little different than before, but they're able to kind of return to independent living. All right, so some of the considerations for rehab. With levels 1 through 3, we're essentially doing bed mobility, range of motion, and caregiver education, how the caregiver can help take care of them and help them avoid having contractures or skin breakdown or any of the risk from long-term immobility. So whenever you're treating, you want to be organized. Sorry, my speaker's messed up. You want to be organized and avoid overstimulating and provide minimal cueing. Just because they are appearing to be asleep or out of it does not mean they cannot hear you and are not actually aware. They may not be able to respond to their environment, but they may be aware of their environment. There's been stories of people waking up from a coma and saying, oh, I remember you came to visit me, or I remember you saying this, because they could hear and they could process some of the things going on in their environment. They just couldn't react to it. So you do still want to say, I'm from physical therapy, and before you move their arm, you might say, I'm going to stretch your arm. So you keep short statements, and then you're quiet the rest of the time you're stretching your arm until you're ready to move on to something else. Now I'll stretch your leg. Whatever you need to do, you do short statements to avoid overstimulating, but you still want to treat them like an actual person. You don't want to act like they're not present because their mind might be there hearing what's going on. Okay, with levels 4 through 6, again, you want to organize your treatment. If they're doing inappropriate behaviors, you can correct them and then give positive feedback for good behaviors, but don't get really caught up in your own emotions if they're saying something inappropriate or being angry during that stage. That's the normal progression of those stages. So just be careful not to be so harsh or quick to get frustrated if you can. Some of the tasks that we would do is functional task, ambulation training, ADLs, caregiver education, You could continue doing some of the bed mobility and positioning and things if they're still going to be in bed a lot. But now we're doing more and more functional training. With a level 7 and up, you're starting to work towards return to their prior level of function. You're trying to help them normalize their movement, trying to help them become more independent and get to a place where they're able to either live on their own or with less and less assistance. Okay, so neurological impairments in general. Impaired motor function, of course, we know what goes into motor function: coordination, balance, gait, speech, hand use, all those things are included. There's a lot more, but these are just common impairments you see with people who have neurological conditions. Sensory loss, it could be any of the senses, not just touch, but it could be taste, hearing, vision, or smell. With sleep disturbances, it's common for people who have head injuries to have difficulty sleeping or to constantly be tired. Maybe that their sleep-wake pattern has been damaged, so they sleep during the day and up all night. Some of the complications medically would be spasticity, epilepsy, seizures, hydrocephaly, so fluid buildup on the brain, heterotropic ossifications, that's bone development where bones shouldn't be, especially in muscles and other tissues. And then sexual dysfunction. Sorry, I thought I was done with this slide. The inability to perform sexually. All right, cognitive impairment. So some of the signs and symptoms: continued memory impairments, difficulty learning, low attention, poor focus, poor thought processing. So poor problem solving, requiring more reaction time to perform a task, decreased organization, decreased ability to plan and make decisions, problem solve through a task, and then language problems. They may have trouble finding words or comprehending words. Could be difficulty reading, could be difficulty writing. Remember, like we learned with the stroke patients, depending on the part of the brain, really determines the deficits. And then impaired judgment, safety awareness. This is very common, so you have to really be careful and stay on them to keep them safe so that they don't, try and jump out of the bed and fall or anything like that. All right, memory impairment. So antegrade memory is the inability to create new memories. So you remember what happened in the past, but ever since the accident, you're not able to create new memories. Antegrade. Post-traumatic amnesia, there's a period of time, a lot of times it's between the injury and when they either wake up or whatnot, that they cannot remember. So, I remember things before the injury, but everything is gone from the moment of injury until they start recalling events again. Retrograde amnesia is the inability to remember what happened before the injury. So that's what they make movies out of. You wake up and you don't know who you are, or don't remember having a family or anything like that. That would be retrograde amnesia. Behavioral impairments and personality changes. Oftentimes people will have decreased self-esteem, social skills, and coping strategies. Denial, becoming easily frustrated, poor anger management, self-centered. Think about like the frontal lobe. So a lot of your higher cognitive functioning comes from your frontal lobe. And of course, not every injury affects the frontal lobe, but a lot of them do. So an immature brain has a lower development of the frontal lobe. So like teenagers, the reason that they're not able to do certain things and make certain decisions until a certain age. For example, the decision to smoke cigarettes or to drink alcohol. We've, as a country, limited it to over 18 or over 21. It's because they have an immature brain and the frontal lobe has not fully developed. And that's where your decision making, your higher level cognitive functioning, your coping strategies, your anger management, your ability to kind of tame your tongue, all those things come from development of the frontal lobe. And so whenever that is damaged, you kind of revert back to this immature state where you're having trouble making those decisions again and becoming really frustrated and difficulty regulating what comes out of your brain. Like I had a friend that was in a coma, and when he woke up, he would say whatever was on his mind, nothing got filtered. Your frontal lobe is your filter, and nothing got filtered. And, it could seem like, oh, that's no big deal, but it is a big deal to the people who are around you caring for you. And your thought is, as a patient, oh, well, that was stupid. And you say that was stupid. Well, now you've offended the person taking care of you. And it's really hard on the caregivers. It's hard on the patient as well. Disinhibition. Inhibition is keeping yourself from doing something. So disinhibition, you don't have the ability to regulate what you do and to say, oh, that wasn't a good idea. Impulsivity, not thinking it through, just going ahead and doing it. Reduced insight, you're not looking at what is this going to do to me in the future. You're just thinking for right here and now. Apathy and low motivation. And then common anxiety disorders that are associated with these are anxiety, depression, post-traumatic stress disorder, and then other psychoses. It can be really life-changing. So educating caregivers on these types of things is important, just as important as understanding them yourself. All right, treatment consideration. So you want to be patient and forgiving. Remember that outbursts are related to the patient's condition, not their personality. They're not just trying to be mean or a mean person. This is their condition. They can't help them. Educate their family members. Let them know that this is kind of a sign of the injury. It's not just the patient being mean. Assess their alertness and orientation every session. It's important to see progress, to see where they're improving, but also to see if there's a decline. Remember, if they suddenly have some more edema or if their intracranial pressure increases or anything like that, they will show a change in cognitive status. And it's very important to note that change early on to avoid any lasting deficits from whatever is causing that change. Monitor for signs of depression, decreased stimulation. Again, you're not talking these big long sentences. You want to have short, concise, easy phrases to follow. Show demonstrations, maybe use tactile cueing or place the person in the position so that you're not overstimulating by constantly talking to them. Making treatment as functional as possible. Remember, if it seems like something they're used to doing or they could see themselves needing to do, like drive or get dressed, they're more likely to do it. All right, role of PT in patients with TBI. So our primary role after somebody's had a traumatic brain injury is preventing their secondary impairments. Remember, those are contractures, pneumonia, pressure sores, blood clots, things like that. So keeping them moving so that they can move. We can assist with early mobility, whether it's bed mobility, transfers, walking. And then we can help teach compensatory strategies for ADLs and for mobility. So say they having difficulty using an arm, we could help show them how to get dressed using only one arm, or use special adaptive equipment to help them with ADLs and things. OTs, typically in hospital settings, will do most of the adaptive equipment assessments and teaching those compensatory strategies, and we will typically take over the mobility portion, teaching them to walk again and move, get up and down with less assistance. And to decrease the burden of care on family. Teach them how to do a proper transfer, how to do proper bed mobility, how to do proper positioning, and help the patient in a way that requires less demand on them. Okay, so things that we assess. We assess the range of motion in order to locate and to prevent contractures. We assess their gait and balance, make sure they're not at a high risk of falls. We assess their skin to make sure it's not breaking down. We assess their level of consciousness and orientation. That includes specifically the oriented to person, place, and time. That's typically what we'll assess at the beginning of each treatment session. We assess carryover between sessions to determine, are they improving? Is there an ability to improve and make lasting benefits? And we assess their mood and determine, are there personality changes? Are there recent cognitive changes? Are they acting different that would alert us that something else is going on? And then if you notice any differences, you report those to the nurse. You don't just put them in your chart and walk away. You make sure somebody is attending to that difference. Treatment considerations: monitor their vitals in all positions. Remember, a lot of people after a coma will have orthostatic hypotension, so their blood pressure bottoms out when they sit up or stand up. So you want to take the blood pressure in various positions to make sure that's not happening. Maintain their blood pressure. MAP is mean arterial pressure. It has a high effect on the intracranial pressure. And so if your mean arterial pressure drops, most likely they are going to pass out because that means their cerebral perfusion has dropped. And then monitoring their oxygen saturation, making sure they're getting enough oxygen throughout the system. Elevate the head of bed, align the head in neutral. Remember, neutral alignment will keep the patient from going into reflexive patterns for all those reflexes that are stimulated by head movements. And a lot of people with brain injuries, once they start to progress and improve, will kind of return to this infantile type of state where they show infantile reflexes, where they reintegrate, they appear again, they'll start to have those reflexes again. Minimize painful procedures, so trying to keep the patient out of pain as much as possible. Of course, that will increase agitation if they are in pain. And avoid fatigue, or at least over fatiguing. The brain really needs everything. It needs to take all the power it can to heal itself, and if power is going to healing the muscles, that's less of the concentration to the brain. So you just really want to move enough to kind of keep some of the strength and keep some of the independence, but avoid over fatiguing or overworking, because the brain needs everything to heal itself. More treatment considerations: avoid resisted strength training to avoid the Valsalva maneuver. Why are we avoiding the Valsalva maneuver? Because it increases intracranial pressure. Remember, if you bear down like that, the intracranial pressure increases, and that increase is not good for a damaged brain or someone who already has edema or a high intracranial pressure. Allow increased recovery time. Make sure you're allowing for rest breaks and plenty of rest between treatment sessions. And then check with the nurse to determine if the patient is adequately rested. Typically in an acute care setting, you're going to check with the nurse before you see the patient ever. So every time, how are they today? Is it okay for me to see them now? You may ask about meds or if there's any changes since the last time before you go in and start with the patient. All right, things that we do or don't do with comas. Things that we do include speaking to the patient in a normal tone. You don't start speaking to them like a child or speaking down to them. We do give concise, short instructions. We do involve family members. We do try and orient the patient even if they are not responsive. Hi, I'm the physical therapist. You could orient them to time and place as they start to get more and more alert. It's September, it's afternoon, whatever you feel is important to start helping them get more oriented to what's going on around them. You do call them by name, and you do give them more time to respond. If you say lift your hand, wait, you may even in your head count to 5 or something before you say or do anything else to see if they're able to do it, because it may take longer for them to respond to that input, to actually can't think of the word, where their brain interpret it and then to be able to do it. Some of the things you do not do: don't assume that they don't understand you. Don't be outside the room talking about them where they can hear you. You don't want to do that to any patient because they may hear you, and that's not appropriate. And again, just because they seem like they're asleep or because they're not responding doesn't mean that later they won't remember some of the events that happen. You also don't want to overstimulate. You don't want to have too much light or too much noise. You don't want to be talking like while you're, something I see a lot is there's a nurse in there and a PT in there, and they're talking to each other about other things as if the patient's not even in the room while the PT is stretching the patient and whatnot. I would avoid that as well when possible because it's overstimulating and it's just not something you would do if the patient was awake. So I wouldn't do it if they're in this type of state either. Some of the treatment activities, you can do treatment activities sitting at the edge of the bed. You could add upper extremity activities, bed mobility transfers, functional reach, reaching for familiar objects, pouring, cutting, tearing, zipping, any functional fine motor or gross motor task. Reaching in a standing position, leaning outside of your base of support, doing balance and gait training, coordination activities, a variety of treatments. Moving on from traumatic brain injury, just kicked my computer on accident. Concussion. This is something we hear a lot about in the sports world, and they're paying more and more attention because of the lasting effects that concussion can have. What a concussion is, it's damage to the reticular activating system in your brain due to a blow to the head. So some type of a direct or indirect impact, and it causes the reticular activating system to be damaged. Now, what that system is, it's neurons that go from the brainstem to the hypothalamus, and they actually are responsible for modulating sensory input and a lot of your body systems. They modulate and regulate those body systems. Some of them include the sleep-wake cycle, fight or flight behaviors, and arousal, consciousness. All of that is regulated by the reticular activating system. So if it's damaged, then it might affect the sleep-wake cycle. It might affect behavior modulation. It might affect ability to modulate your movement. So I have a cup here and I'm trying to gently grab the cup and bring it to my mouth, but I overshoot and I push it away, or pick it up like it's a big empty jug of milk, to be able to modulate and regulate the use of the motor system and other body systems. There are grades of concussion. There's 3 grades. So 1 is the lowest, 3 is the highest. With 1, the person initially seems confused, but all their symptoms resolve within 15 minutes. So unfortunately, with this type, most of the time, the parents don't do anything because they're like, oh, they're fine now, so we don't need to go to the doctor. And they keep going like normal. But the truth is, they really do need at least a week of rest to fully recover. So even though they may seem like they're okay because all their symptoms resolve within 15 minutes, their brain was still damaged during the impact and still needs long-term recovery. So they should stop playing their sport for at least a week. And if within that week the symptoms don't return, they need to be symptom-free for a full week, then they can return to the sport. Now, the thing about this is rest. A lot of times when they're resting, what are kids doing when they're at home resting? They don't go to school for the week. They don't play sports. They're probably watching TV and playing video games, which is actually the worst thing for them to do when they have a concussion, because those things are very stimulating. And the rest that they need is minimal stimulation to brain activity. Their brain basically needs to be in a state of rest. And that's really difficult to do when they're at home wanting to watch TV. So you really need to decrease the TV and the other input. And even the schoolwork. I would suggest keeping them home from school during that time, and they may have to wait until that time period is over before they can even do their makeup schoolwork, because that's very stimulating for the brain. A grade 2 is a moderate head injury. The confusion lasts for more than 15 minutes. They may continue with poor concentration. They may have some sort of amnesia. Remember, retrograde, not remembering what happened before the injury. Antegrade, not remember what happened, or inability to make new memories. And then they may have to, definitely remove them from the sport. Sorry, they need to be removed from the sport. They need to stop playing. If their symptoms get worse, they certainly need a CT scan, and they do not need to return to the sport until they are symptom-free for at least 2 weeks. This is really key because a lot of sports teams are going to push for them to come back ASAP. And then if you come back with an unhealed injury, then it's more likely to get re-injured and you're more likely to have lasting effects. So this is these football players that have pushed through for years and years, and then all of a sudden they have these, symptoms at a young age of either Alzheimer's or Parkinson's disease. They're having some of these symptoms. Boxers, a lot of people that really didn't give themselves enough time to rest. All right, and a grade 3 concussion, any concussion that causes a loss of consciousness, LOC, loss of consciousness. Any head injury with a loss of consciousness is a grade 3. Even if they're out for a few seconds and they stir back up and they're kind of wiggly headed, that was a loss of consciousness, is a grade 3. They need to go to the ER. They need a full neurological evaluation. They need, if their state decreases, they need to go back to the hospital. If the symptoms persist for a long time, they need to go back to the hospital. And then they cannot return to the sport until they're symptom-free for a minimum of 1 month. So this is a long duration healing process. So if they are knocked out after a tackle, if they're knocked out after a punch, they need to be off for a full month. That doesn't usually happen, but it needs to. And then axon injury may occur with this. It may send the patient into a coma. You all have seen where recent boxers got knocked out. They thought they were okay, and then they had a brain bleed. And so you have to be really careful and really make sure that the patient is okay and rests and lets the brain heal before returning to their activities. Okay, we're going to switch gears and talk about Parkinson's disease. This is a hypokinetic disorder. It's characterized by increased activity of the basal ganglia. The basal ganglia sends an inhibitory signal throughout the body. So the basal ganglia kind of allows you to rest after your fight and flight. This is kind of rest and recover. That is the basal ganglia that's responsible for that. So when it's time to sleep, your basal ganglia kind of kicks in, sends an inhibitory signal, and allows you to relax. But with this disorder, it's too active, and so there's a constant activation or a constant inhibitory signal sent throughout your body. So your muscles are getting a constant cue to relax. And so then it's a lot harder to activate the muscles because you're working against the cue that they already have to relax. Dopamine levels are low and allow this message to continue. Dopamine, one thing I was going to say about dopamine is necessary to send nerve impulses. So it hangs out in the neurosynaptic junction, and it increases the ability to pass impulses from one neuron to the other. And so it helps you with neuromodulation, it helps you with motivation, it helps you with cognitive functions. So it's key for all those things. So those are some of the things that are going to be affected in a patient with Parkinson's disease: their ability to modulate their movements, their ability to be motivated and to initiate movements, and their cognitive functions. So here's the presentation. Typically, they will demonstrate a freezing of gait where they're walking and then they start shuffling and kind of stop and get stuck in an area. Shuffling gait, barely picking up their feet, just kind of scooting them along the surface. Difficulty initiating movement. You say lift your arm, and it takes a long time for them to actually follow that command. Doll face is where their brain is, or their face is kind of stuck in a non-expressive state. So it's just kind of a flat affect, and it's hard for them to make facial expressions. Falls are common. Falls are often related to their posture and their inability to quickly react. Remember, power creates a higher fall risk, decreases in power than decreases in strength, because you can't use your strength functionally if you don't have the power. With Parkinson's, you often see tremors, specifically pill rolling. So they'll start out with kind of a tremor where it looks like they're rolling a pill, or their whole wrist is kind of doing a screw kind of tremor. Small movements feel like large or normal movements. So you say, lift your arms like this, and they lift up there, and they feel like they're doing what you've asked them to do. And then kyphosis and decreased spinal mobility, the back becomes rigid and stuck in more of this rounded pattern. In treating patients with Parkinson's disease, one of the common treatments, this is something that PTAs can get certified, is LSVT big therapy. So you're emphasizing large movements in order to help them increase their initiation and increase their movement magnitude. If they're doing these little small movements and feeling like they're large, you target, train them to do over exaggerated movements. And so then if their brain is saying do this, they may actually get this, which is what you might have wanted in the first place. So pushing them to do increased large movements, and that has a great effect on the patient. Gait training, some of the things you might want to do is work on turning, that can freeze their gait, on backing up, on stops and starts, the ability to initiate their game. Walking between converging lines. As the lines converge, oftentimes it kind of tricks them into thinking that they're walking into a corner or something, so their brain will cause them to do that freezing of gait. So if you put some lines on the floor that kind of converge together, then you can help them practice overcoming that signal from their brain to stop. Balance activities, postural control, whether those are in seated or standing, all of these things would be appropriate for someone with Parkinson's disease. All right, that is our PowerPoint for traumatic brain injury and Parkinson's and all that. And now we are going to talk about multiple sclerosis, ALS, GBS. So we'll go through all this. So multiple sclerosis. So it's a chronic demyelinating disease. It's of the central nervous system, and the myelin that surrounds a healthy nerve and sends impulses along the axon becomes damaged. Okay, so myelin is the white portion. It's kind of surrounding the nerves. I have a picture of it on the next slide. It becomes damaged, which causes the signal to move more slowly and become less intense, because myelin is also kind of like an insulator. If you think of a thermos with hot liquid in it that is insulated, it stays warm for a long time. If it's not insulated, then it's going to lose a lot of that heat. So it's the same thing with the axon. As the signal passes down the axon, the myelin keeps the signal in, like insulation. And if it's damaged, then it allows the signal to kind of disperse out rather than being pushed forward, and it becomes weaker and weaker as it travels. There are sclerotic plaques. That's like a scar-like lesion. They show up white in this MRI picture, and they form throughout the brain and throughout the spinal cord. So remember, upper motor neuron, multiple sclerosis is upper motor neuron, which means it's the brain and the spinal cord that are affected. Some of the common areas that are affected is the optic nerve, which of course is a lower motor neuron, but is the optic nerve, the periventricular, the white matter in the brain, the cortical spinal tracts, the posterior columns, and the cerebellar peduncles. I don't care that you have them memorized, but just in understanding the effects of MS, it's important to understand what areas are affected, and that causes the damage and the symptoms you see. For example, one of the most common first symptoms that occur that people kind of cue people to go to the doctor is vision changes. So sudden vision changes, and sometimes it will be the ophthalmologist that kind of first starts thinking about MS and has them go to a neurologist and get worked up further. The pathophysiology, so demyelination of the white matter, so this is what I was talking about, the part that insulates and surrounds the myelin sheath around the axon, starts to demyelinate. So it starts to kind of unravel, break apart, tear throughout the brain and the spinal cord, and it's due to destruction of the oligodendrocytes. This is what makes up the myelin sheath, and what surrounds the axon. The axon then is unprotected, so it can become damaged easily. It also can become inflamed, and it forms those plaques. So the plaque is basically like scar tissue developing on that axon. And remember, scar tissue is not a good conductor of a nerve impulse. It basically kind of stops the impulse when it meets scar tissue, so it blocks the impulse from getting through. Plaques are replaced by scar tissue, and that causes further axon degeneration. So in a normal Schwann cell, there's the axon, the blue part in the middle, there's the myelin around, and the nerve impulse kind of jumps from one what do they call it? Node of Ranvier? I'll have to look that up, to the next, but it basically jumps down the sheath and creates a very fast impulse where you can quickly react. As it gets damaged, it slows down how quickly the impulse can get to the muscle, but also by the time it gets to the muscle, a lot of the impulse has been lost, and then it's a smaller impulse that's getting through. Some of the presentation of multiple sclerosis: muscle weakness, abnormal sensations, so paresthesias, which is kind of numbness, tingling, pins and needles type feelings, burning, or dysesthesias, it's more the burning and aching, abnormal sensations. Paresthesias like decreased sensation versus dysesthesias are more abnormal sensations. Abnormal vision, whether it's gray or blurry, could be double vision, could be nystagmus, where your eyes are jumping back and forth. Poor coordination, difficulty speaking and swallowing, might have slow, long pauses, not fluid speech. We call that scanning speech, where they're just kind of thinking really hard about what to say. The patient will become fatigued. They may have bowel and bladder issues, including constipation, urinary retention, urinary frequency. All of these are common signs of multiple sclerosis. Types of multiple sclerosis. There's a relapsing remitting. That's the most common. That's represented in blue here. You have a spike of symptoms where the symptoms are really bad, and then you kind of go close to your baseline, and you go for a while without any true symptoms, and then you have another episode, and when you come back down and you recover, you don't fully recover with any of them. You don't fully recover back to what you started. So it does over time make you more and more weak, but there's periods of exacerbation, significant weakness, and periods of recovery where you're starting to gain a little bit of your strength back. The symptoms don't completely resolve, but become less debilitating during the recovery periods. The problem is with this over time, the remission periods become shorter and shorter, and the exacerbation periods become more and more frequent. With primary progressive, that is the green line here. There's no remission periods. It's just they're getting weaker and weaker. There's no recovery periods. It's a very rare, but that's detrimental, really. That's a hard one. Secondary progressive, that would be this orange, where they kind of start out, it's kind of like relapsing remission. Most of the time it starts out as relapsing remitting, and then over time it gets to a point where there's no longer recovery periods. They just get more and more weak, and less recovery after each episode. And then progressive relapsing, which is this red, is basically that they have periods where there's symptom exacerbation, and then the recovery periods really aren't a full recovery. They're still kind of getting weaker and weaker as they recover, and then they have a really hard episode, and then they continue to progressively, slowly weaken. All right. MS is diagnosed by an MRI. They can see those sclerotic plaques formed in the brain. And there are medications that can be given. They decrease the severity of the attacks. They may decrease how long the exacerbation periods last, but they do not completely cure the disorder. treatment considerations. Okay, only strengthen within a submaximal heart rate and avoid over fatiguing. When we strengthen somebody, we typically break the muscle down, and then as it's built up, it's built larger and stronger. Well, in this case, with anybody with any of these disorders we're about to learn about, we don't want to break the muscle down because it may not build back up. It's going to just continue to be broken down. So you really want to avoid over fatiguing, keep them at a submaximal level. Remember, the heart is a muscle too, so you don't want to overwork it either. You can stretch patients before exercises. Of course, you hold the stretches 30 or 60 seconds. Some of the common areas of tone are their hamstrings, their neck muscles, their heel cords or Achilles tendon. With ataxia, sometimes you can put weight belts or put some type of a weighted vest or something centrally to weigh them down, and it can help them control and coordinate their movements more and have a little bit of an increase in proprioception and feedback. Typically, if you're using weights, especially in the hands or on the legs, you may think they're strengthening, but it may cause them, once you take the weight off, to overshoot. So they've practiced bringing their arm up with a weight, and now they go to do a functional task and they do it too hard because they've been practicing with the weight. So typically, if we are using weights with someone who has MS, they use them proximally, not distally. So more of just body weight type movements distally, and then centrally you could use the weight to help control some of that spastic movement. Moving on to a different diagnosis, ALS. So Amyotrophic Lateral Sclerosis. It's also known as Lou Gehrig's disease. This is a terminal progressive disorder involving degeneration of the upper motor neurons and the lower motor neurons. So with MS, it only involves the upper motor neurons. With ALS, it's both the upper motor neurons and lower motor neurons, but it's also terminal. It progresses until the point of death. It will lead to death, and typically death will be based on respiratory failure. It could be also complications like aspiration pneumonia, so where their swallowing muscles are not quite strong enough and they aspirate on a liquid or something that they're eating or drinking. So rather than going to their stomach, it goes into their lungs and causes pneumonia. The attacks are on all voluntary muscles. These include the respiratory muscles, the diaphragm, and typically those who are diagnosed with ALS will die from the condition within 3 to 5 years. Some of the presentation, there's muscle weakness, stiffness, cramping, and atrophy throughout. So muscle wasting, it's just kind of wasting away, getting smaller and less useful. Fasciculations are twitches. They have difficulty swallowing, difficulty speaking, very tired. Typically, the symptoms appear distally first and then progress to proximal. So they have symptoms in their fingers and toes and even in their face before they start having symptoms throughout their trunk. That's really key in knowing, because a lot of the other progress in the opposite fashion. So with ALS, it typically will start more distal and progress proximally. And not necessarily, when I say a lot of the others, I'm not necessarily just talking about brain injuries or anything. I'm talking about just symptoms, other conditions. A lot of other conditions start proximal and progress distal, but these are from distal to proximal. They may have some cognitive deficits, may not, have dementia. And then typically their sensation is not affected. So they will actually have full sensation, but loss of motor control. Diagnosis, they must have upper motor neuron and lower motor neuron in at least 3 of the domains in order for them to be diagnosed with ALS. So the domains are bulbar, cervical, thoracic, and lumbosacral. This would be diagnosed by a medical doctor. Reluzzo is the only drug right now that actually decreases or slows the progression of the disease, but there's other drugs that are out there that help symptom management. So there's drugs that can help them feel a little bit better, but it's not going to actually slow the progression of the disease down. In the early stages, the primary treatment, we would mainly avoid heavy eccentric exercise. If the muscle that you're exercising has at least a grade 3 out of 5 muscle strength, you could do some resistance training, but you don't want to do resistance training with muscles that have a less than 3 out of 5 muscle strength. Okay, that's just can lead to overuse. In the later stages, you're mainly helping them focus on supporting the weak muscles, on adaptive exercises, modifying the environment so that things can be done more independently, maybe adaptive equipment to be more safe, caregiver training to help them know what to do to help the patient, and then balancing their treatment and their rest periods and allowing for increased recovery time. You do not want to overwork. You do not want to overuse and cause delayed muscle onset soreness or anything like that, because it will bite you in the butt. And by that, I mean it will lead to further damage. We don't want that. I'm sorry to laugh about my own phrasing. That wasn't okay. Guillain Barre Syndrome. This represents a broad group of demyelinating inflammatory polyradiculoneuropathies. Poly meaning many, radiculo like radicular symptoms radiating down to the extremities. Neuropathies is either damage or a disorder of the nerves. And so Guillain Barre syndrome is not just one. There's several disorders that are under Guillain Barre syndrome. But all of them are lower motor neuron only. So MS is upper motor neuron, ALS is upper and lower, and Guillain Barre is lower motor neuron only. It damages the nerve root, and that includes the cranial nerves. Remember, cranial nerves are lower motor neurons. It also damages peripheral nerves, and it can result in flaccid paralysis. So the muscles are paralyzed and just hanging. That's the flaccid part. Typically, symptoms begin distally and progress proximally, just like with ALS. They begin in the fingers and toes and then progress up the arms and legs. There are two major subgroups. One is acquired inflammatory demyelinating polyradiculoneuropathy. Another is acute motor axonal neuropathy. With acute motor axonal neuropathy, it's purely motor. It doesn't have a sensory component, but it could cause respiratory failure because it also attacks the muscles of respiration as well as the diaphragm. Guillain-Barré is signaled by an autoimmune response, and often that in itself is triggered by an infection. The autoimmune system the immune system ends up attacking itself, its own nerves. So oftentimes, most of the time, it's associated with someone who's had a virus within the last 6 weeks, but they have also found cases where it's associated with either a recent surgery or a recent vaccine. Specifically, something that would matter to you all was the Johnson & Johnson vaccine, the COVID vaccine that was recalled. The two major things that people were having issues with was blood clots and Guillain-Barré syndrome. So some people were getting that from taking the vaccine. What it does, it demyelinates and causes inflammation throughout the neurons, which leads to slow or blocked nerve conduction. So the impulses cannot get through because the myelin is damaged and there's inflammation. Once the inflammatory process stops, the Schwann cell begins to regenerate. The cell remyelinates, and then it returns to its more normal state. So the time frame between demyelination and remyelination is typically 2 to 3 weeks. Typically, immediately, it causes acute paralysis. This is one of actually the most common causes, or it is the most common cause of acute paralysis. If randomly somebody becomes paralyzed and there was not a spinal cord injury or anything, this is something they're definitely going to need to look into and rule out before they look at anything else. And it's typically about 2 or 3 weeks before remyelination starts to occur and they start to see movement returning to those paralyzed areas. Typically distal paresthesias, so numbness, tingling, burning, decreased sensation, or hypersensitivity of the toes. That's often one of the first symptoms. They also become weak in their limbs, including their diaphragm and the muscles of ventilation. Because of that, most of the time they are treated in the hospital while they're in the acute stages so that they can stabilize their breathing and make sure that it doesn't become life-threatening, because it can. The autonomic nervous system has some symptoms like fluctuating blood pressure, poor venous return or blood pooling in extremities, tachycardia, arrhythmias. So remember, the heart's a muscle, so it's not getting normal impulses. Remember, the venous return is highly impacted by muscle pumps. A lot of your venous return is pushed back to your heart from the muscle pump activation. And if that is not intact, then you have poor venous return. So the blood begins to pool in the extremities. Myalgia, that's muscle pain. It may be because of spontaneous nerve firing, where the nerves are demyelinated. They may spontaneously throw impulses down the nerve that is interpreted as pain. Difficulty speaking, dysarthria. Remember, if your tongue and your lips, all of that is a muscle. Difficulty swallowing, that's dysphagia. Facial weakness, double vision, areflexia, absence of the deep tendon reflexes. So a large clinical presentation, very involved, but luckily quite a few of the cases resolve. So with the acute symptoms typically last up to 4 weeks. That's when the symptoms appear and progress, get worse. And that can last up to a month of the symptoms getting worse. The plateau, they begin to stabilize. They're no longer getting worse. That typically takes up to 4 weeks as well. And then the recovery is when they start improving. And once it starts, it may take up to a year or even longer. And an article I was reading earlier today said 80 to 90% of people have the ability to walk within a year of having Guillain Barre Syndrome, but the others have residual symptoms that last. So there may be some residual weakness or paresthesias, and in some cases it will be lasting. They will not recover. They'll continue to have symptoms. Treatment considerations. So during the acute phase, our primary goal is to minimize their symptoms, to support their lung function, to prevent secondary complications. So somewhat like what we would do with someone who's in acute stage with MS or ALS or any of that. We're just trying to keep their condition from progressing and getting worse or from causing secondary issues. We also can help with pain management and patient and caregiver education. Many of these patients will initially be in the ICU because of the difficulty breathing. During the plateau stage, we focus on getting the patient used to that upright position and trying to counteract that orthostatic hypotension, on maintaining their range of motion so they don't get contractures, on improving their breathing, their pulmonary function, avoiding fatigue and overexertion. And then once they reach the recovery period, you start to strengthen and get them to their maximal functional mobility, getting them back to their prior level of function. Let me see if there was anything on any of these slides I needed to say. Yeah, I already did. Okay. So these Bensman recommendations are just recommendations on treatment considerations for people who have Guillain Barre syndrome. So use short periods of non-fatiguing exercises that match the patient's strength. Increase the difficulty of an activity or level of exercise only if the patient improves or if there's no deterioration in status after a week. That's with all patients. We don't progress an exercise unless we've given them at least a week of doing it to make sure they don't have delayed onset muscle soreness. Return the patient to bed rest if they suddenly have a decrease in strength or in function. That means they've overdone it and they need to really heal before they do more activities. And direct strengthening exercises at improving function, not just getting stronger. So anything functional is key. Treatment more treatment considerations. Overworking a denervated muscle produces profound decrease in muscle ability, and that includes strength and endurance. So we do not want to overwork a partially denervated muscle. So if it's demyelinated and there's not a lot of impulses, you do not want to overwork it. Signs of overuse, of course, we know delayed onset muscle soreness. So if you're more sore 1 to 5 days after, then that's a sign of overuse. A reduction in the maximum amount of force that is that the muscle is able to generate. So they've lost some strength and some force. One of the treatment considerations is starting with low reps, short, frequent bouts of exercise. So do a little exercise, rest. Do a little exercise, rest. And then make sure that to include endurance training in their home exercise program in order to increase muscle endurance. Okay, so a lot of our treatment will be more on endurance activities and functional activities than just resistance training. All right, that is our lecture for today. And if you have questions, please just let me know. And I hope you all have a good day.